Improved ejection fraction is an entity apart from if you divide three categories of heart failure with ejection fraction, as per the heart failure guidelines, reduced ejection fraction is less than 40%. Mid-range ejection fraction or mildly reduced ejection fraction is around 40 to 50%, and more than 50% is preserved ejection fraction, HFpEF. Now, improved ejection fraction patients are such patients who have a 10-point increase in ejection fraction above 40%. So basically, they have ejection fraction which is less than 40% to begin with, and with the treatment with various ARNI and other drugs, the ejection fraction improves by at least 10 points to end up being more than 40%. So for example, if the patient has ejection fraction of 30% to begin with, and there is a 10-point or more, like the 15-point, I'll say, improvement in ejection fraction, so that the ejection fraction now is 45%. So to begin with, it was 30, now it is 45. Such patients are called as heart failure with improved ejection fraction. There is a separate category for such patients. Now, with that, I tell you that now if you compare HFpEF patients, hardly 60 to 90% remain HFpEF. Maybe 10-20% actually, deteriorate ejection fraction is deterioration in ejection fraction is seen, and 10 to 20% will become with mildly reduced ejection fraction patients. In fact, 2 to 20% can be reduced ejection fraction patients. Similar for the mildly reduced ejection fraction patient, 30 to 40% only will remain, and maybe 20-30 can have a reduced ejection fraction, 30-40 can have an improved ejection fraction. Similar for HFrEF patients. HFrEF patient around 60 to 80% can remain the same, but many of them, maybe 10 to 20%, will actually have HFpEF, absolute improvement in ejection fraction, more than 50%. Or there will be a 10 to 20%, another subset which have mildly reduced ejection fraction. Maybe the ejection fraction will be 40 to 50%. So basically, this is a continuum. It is not a separately, separate entities. They are in a continuum, and reduced ejection fraction can actually change with the treatment, and it can be an improved ejection fraction also. And what are the 2022 AHA guidelines? Improved LVEF is used to refer to those patients with previous HFrEF who now have ejection fraction more than 40% and have at least a 10-point improvement from the previous ejection fraction. And what are the recommendations in patients with mildly reduced ejection fraction patients? Guideline-directed medical therapy should be continued to prevent relapse of heart failure and LV dysfunction, even in patients who may become asymptomatic. So even if the ejection fraction is improved, don't stop this molecule, otherwise the benefits might go away. So what are the pearls of consensus? ARNI is the molecule of the century, there's no doubt about it, and is an indispensable molecule, and is definitely much superior to ACE inhibitors in reducing the cardiovascular deaths, heart failure hospitalizations, and improving the quality of life of the patient, whether HFrEF or HFpEF, or even heart failure with improved ejection fraction, or heart failure with mildly reduced ejection fraction. ARNI also improves the ejection fraction in HFrEF and reverses the adverse LV remodeling, and improves the quality of life as per the Kansas City Cardiomyopathy Questionnaire in both HFrEF or HFpEF patients. ARNI should be initiated as early as possible in patients with ADHF or de novo heart failure. Here, time is life years. In fact, it has been shown that 9 years is the time which you achieve with starting this molecule early. So you can have a life more by 9 years. And ideally, this should be started well before discharge of the patient, or as early as possible whenever it tolerates. It should be given at least for 3 months, ideally to 3 to 6 months, along with other foundational 4 therapies, as I've mentioned, before putting an ICD or a CRT. Because if the patients are not responding or not responding less, and ejection fraction still remains less than 35%, so in such patient, you can put an ICD or a CRT. And ARNI should be used in all patients with HFpEF up to ejection fraction of 57 to 60%, along with SGLT2 inhibitors to reduce the heart failure hospitalization and improve the quality of life of the patient. So I think with that, I would like to thank you for a patient listening. Thank you.